Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. My guest this evening is Dr. Garry Ruben, a noted vascular surgeon practicing right here in Montgomery County. Dr. Ruben, welcome to Housecall.
Thank you.
Tell our viewers briefly about your professional background.
Well, I'll start by saying I'm a native Washingtonian and grew up in Silver Spring. I'll put in a plug for Springbrook High School. But beyond that, I got my bachelor's degree at Tufts University in Medford, Massachusetts. Went to the University of Maryland School of Medicine, got my medical degree in 1977. From there, I did a general surgery residency at the University of Pennsylvania. That was a 6-year period. From there, I did a vascular fellowship at Albert Einstein Medical Center. Was in practice for a year in New Jersey, but came back to this area because I have strong family roots.
Yes.
And I've been in practice, believe it or not, in the same office building, in the same office in Silver Spring in the White Oak area since 1986.
Very nice. Tell our viewers briefly, what exactly is a vascular surgeon?
So, vascular surgeon is sort of a part of general surgery, but a specialty of it. And it involves diseases of the blood vessels outside of the heart and outside of the brain. When we talk about blood vessels, we're talking about both arteries and veins. And just to, if your audience doesn't know, arteries carry blood from the heart out to the entire body to supply the body with nutrients and with oxygen. Veins then have to return it to the heart. Most of the serious problems that we deal with tend to be with arteries, but venous problems, which people are very aware of, varicose veins and so on, are also part of the specialty. And so vascular surgeons both get the education and training to deal with those problems. Now, I would have to say that whereas we call ourselves vascular surgeons because our training it comes from the surgical field, so much of what we do has nothing to do with surgery. A lot of it is, first of all, figuring out whether somebody has a vascular problem versus another problem, whether it's even something that would merit any kind of surgical intervention. Because most of the patients that I see, for example, they may have a vascular problem, but as I tell all my patients, don't get operated on unless you really need to.
Sure.
And I think that certainly holds for a lot of our patients.
You mentioned venous problems and arterial problems. So let's start out with the venous problems, in particular what you call PVT. Define that for our viewers.
Well, okay, so peripheral venous disease can be a lot of things. Okay. What most of your viewers would be thinking about would be one of two things, either varicose veins, and we could talk about that a little bit, but also things like clots in the veins, DVT, which is, you see things all about it on TV, which is deep venous thrombosis, meaning blood clots in the veins, and it can occur in the arms as well, but generally it's in the legs. One of the possible complications of that, as many people are aware, is to throw one of those blood clots to people think of it going to your heart. They actually go through your heart and into your lungs and can block off the blood flow to your lungs. If that happens, it could have very serious consequences. One of the things to understand there is that we are generally talking about clots in the major deep veins of the leg. A lot of other people do get clots in the superficial veins, and that doesn't really pose the same kind of risk. The risks for getting DVT, as many people know, would be sitting for a long period of time, such as on an airplane, injury to the veins, and some people do have what we call hypercoagulable disorders. Simply means that under normal circumstances, you want your blood to clot when you cut yourself, because you certainly don't want to not stop bleeding. That mechanism of blood clotting is a very, very sort of almost like on a tightrope. You don't want it to go one way or the other. And some people, it goes a little too far one way, and they can get these clots. And the clots can, what we call, propagate. They can get bigger and bigger. And that's where one could break off and go to your heart and lungs.
So in other words, those people with hypercoagulable states, they clot inappropriately.
Correct. And it is occasionally associated with certain cancers. That's pretty rare. And most people have a family you'll know about it because you have a family history of it. There are certain things we talk about and tests that we can do to look for it. It's not common, and we really don't look for it unless somebody's had a problem with clots in their veins.
So lots of people, of course, have long-distance travel, or they may have other things that put them at risk, smoking or other things for deep venous thrombosis. So our viewers are wondering, what exactly are the signs of deep venous thrombosis?
Okay, generally speaking, it could be leg swelling. Again, you can get it in your arms, but it's much less common.
Yeah.
But mainly leg swelling, pain in the leg, and sometimes you'll get some redness or some inflammation in the leg as well. You can get it without any symptoms at all, and unfortunately that can be a problem with this. Generally speaking, it's not something you would worry about on a day-by-day basis. Certainly if you take a 12-hour plane trip and you get off the airplane in Budapest or wherever and your leg is swollen and painful, certainly that's something you would want to go immediately for emergency care. It's easy to diagnose. It's done by ultrasound now. When you and I were very young, it was a little more difficult because we didn't have some of the studies we have. But now with simple ultrasonography, that can be very quickly checked for and dealt with. And the way it's treated is with what we call anticoagulation. Your viewers will commonly hear the word blood thinners. It's really a bad term. I try to dissuade my medical students and residents from using it. If the paint's too thick to go on your wall, you add either water or turpentine and it thins the paint. What these medications do, and there are now a variety of them, is to simply slow the clotting process so that people won't keep making these clots, and that it reduces tremendously the risk of having those clots grow, break off, and go to your lungs.
And then what happens to the clot that's already there?
Good question. Several things can happen. In some people, the clots can dissolve on their own. And certainly we have a lot of patients who will get a DVT, we'll follow them, we'll get repeat ultrasounds, we'll have them on these medications, and lo and behold, the clot will really dissolve. Your body actually has mechanisms to dissolve clot. In fact, one of the early, what we called clot busters, the medicines that we would actually use to break up clots, one of the first ones was synthesized from urine, and it was called urokinase. We don't use it anymore. We have something better. But in fact, your body, it was made from urine because your body would put it into the urine. And interestingly enough, one of the reasons for that, presumably, would simply be that if you have blood clots from bleeding inside your urinary tract, you want those blood clots to dissolve because otherwise they could block you up.
Right.
That could happen. However, it can also happen that those blood clots will scar down the veins. And then you can get an impedance of the blood flow back to the heart. This is where people get chronic swelling in their legs. The medical term for that is post-thrombotic syndrome. Just means, you got a problem because your veins never opened up and the blood can get in, but it can't get out, and people can get chronic swelling, chronic discomfort, and so on.
Besides anticoagulants, I didn't say blood thinner.
Thank you.
What other therapies can people utilize to get symptomatic relief?
Well, these days, depending upon the patient and the severity, we can use these clot busters. What we call them, they're called thrombolytic agents. The one we use now is TPA, which is tissue plasminogen activator.
Right.
They will dissolve clots, but they do have some risks to them, and clearly the obvious one is they can cause you to bleed. We are always doing things to ourselves that we don't know about, where we get a little bleeding from little blood vessels, and because of the clotting mechanism, that stops. These medications can cause bleeding elsewhere, such as in the brain or people with ulcers or recent surgery. Mm-hmm. We generally don't use them unless the clots are causing a real problem. But there are times, for example, we'll get young patients who clot their arm. One of the common things we see are swimmers. Right. And they will get what we call an exercise thrombosis, and their arm's swollen. And if you don't relieve that, they're not going to get much better. And if they're young, it can be debilitating the rest of their lives. Sure. So in a certain subset of patients, we will use these thrombolytic agents. But for most patients, it's going to be anticoagulants, blood thinners, and for at least 3 months, and sometimes longer for certain reasons. And most patients will usually get better either by dissolving their clot or creating new channels around the blocked veins, and the swelling will not be a significant problem.
I know for many years, besides all the things you've mentioned, there was also popularity for leg elevation and using support stockings. Is that still utilized?
Very much so. We have a lot of patients who do get chronic swelling in their legs. Now, that's less because of the thrombosis and more because of the reasons we get varicose veins, which I guess we can sort of segue to.
Right.
Getting blood out to your body is a pretty active process. Your heart's pumping it under fairly high pressure. It's going through the arteries, and with respect to your legs and feet, it's going downhill most of the time.
Right.
And unless you walk on your hands a lot, it's never going uphill. To get that blood back to your heart is a much more passive process. There is some pumping on the veins when you walk, but essentially that blood has to fight gravity. And the way it does so is that in all of your veins, but particularly in the ones in your legs, there are little valves, one-way trapdoors that literally let the blood go up towards your heart. But when you sit or stand, as we are right now, they will shut and they will stop the back pressure of the venous blood. The way I tell my patients about it is I live not far from the water tower at Lay Hill Road, and if you imagine that the water pressure at the bottom of that tower is tremendous, if you had a valve there and you opened it up, it hit you in the chest and knock you across the street.
Sure.
But if you had a series of stop valves all the way up and you measured the pressure at any point, it would be a very low pressure. That's how we're supposed to work. But those valves, for a variety of reasons, do not last forever in people. Aging, family history, history of deep venous thrombosis, obesity. There's a number of things that will render those valves incompetent. They literally break down. So now you've got a column of pressure of blood and fluid forcing the fluid back into the tissues, and you get the chronic swelling. And along with that, you may get some achy discomfort in your legs. You will get some varicose veins that protrude. And the non-surgical or non-interventional treatment for that is exactly what you said. Elevation of your legs when you can, and what we call graduated compression hose. These are stockings that are generally measured for the patient. You can get them at a surgical supply store with a prescription. And they come in a varying degree of compressions, but essentially they're made so that there's a tighter compression down at the ankle level, and it gradually eases up as you go up the leg, and that tends to force the fluid out of your legs. The problem with those is getting them on, if they're strong enough to really work, getting them on can be quite an affair.
Because of the leg swelling?
No, because they're tough to get. Well, it's just they're tight. Whatever you measure them for, they're going to be really tight. I had a company send me a pair several years ago. I'm a fairly healthy guy. And they were the 20 to 30 measurements, which is fairly medium. And it would take me 4 or 5 minutes to get them on in the morning. A lot of patients don't want to deal with that. But they do work, and they're very good.
We have a minute before we go to break. Tell our viewers what they can do if they are going on a long flight to reduce the risk of developing deep venous thrombosis.
Well, the first thing I say to my patients, and it's sort of true, but it sounds silly, is fly first class, because your legs are up.
Sure.
But honestly, I think the biggest risk factor, in my opinion, is falling asleep with your legs in one position. You know, when you're awake, you're sort of moving your legs and you're sort of moving around. I think it's those overnight flights where you fall asleep with your legs drawn up. So the answer is try not to fall asleep for several hours in one position. Do try and move around. You don't really have to get up and walk, but you just want to sort of roll your feet around, do little leg exercises at your seat. Whether or not taking an aspirin before you go might be of help. I don't think it's ever been proven, but it's not unreasonable. Certainly people with a strong history of a problem, we would deal with differently. We might give them a dose of an anticoagulant before they left.
Okay. And what do you say to the passenger who gets off a plane, their leg is swollen, one leg, let's say, and they say, oh, let's wait and see what happens?
I think that's a bad idea. And I don't want to overly alarm anybody, but if that's the case, you need to go right to an emergency center and get an ultrasound to make sure you don't have it. Unfortunately, that could cause sudden death. I mean, I don't want people running around hysterical, but if you really take a long trip like that, car, train, whatever, and your one leg really becomes swollen, or even both conceivably, something you've never experienced before, it doesn't take much to make sure you don't have it.
Because if you ignore it and a clot chews up to your lungs, you're in trouble.
You could die suddenly, quite frankly.
With a pulmonary embolus.
A pulmonary embolus, correct.
Garry, thanks for the opening to our show. We're going to pause briefly for a public service announcement. More with my guest, Dr. Garry Ruben, Vascular Surgeon, in a moment. We'll be right back. We're back. My guest this evening is Dr. Garry Ruben, vascular surgeon practicing right here in Montgomery County. Dr. Ruben, when we closed out the first half of the show, we were talking about venous disease. Very briefly, tell our viewers about varicose veins.
Well, varicose veins are a result of what we were talking about earlier. When the valves and the veins break down, there's a lot of back pressure. Veins are actually very thin-walled as opposed to arteries, which we probably will talk about a little bit later.
Yeah.
Because they're thin-walled, they can literally expand, much like blowing up a balloon, but instead of over a few seconds, it's over several years. And it's with those breakdown of those valves and the back pressure, they simply get larger and larger. There are several sort of kinds of varicose veins. They're the big bulging ones that people see that look purplish in color under the skin. Those are just veins that were under the skin and got much bigger, and they were somewhat big to begin with. There's also the spider veins that look like little spiders, or as I say, if you're old enough to remember road maps in the 1960s and 70s, it looks like an old road map with the red and the blue lines all over it. Those are actually the same thing. Those are what we would call dermal veins, or veins within the skin, that are actually microscopic when they start out. That's why you don't see them, but they also get larger. Varicose veins rarely have to be treated. Okay, I'm not saying they shouldn't be treated, but rarely have to be treated. They're now, in the old days, we used to do what we call vein strippings. It was a significant operative procedure to remove the veins. Fortunately, that's generally not necessary anymore, and there's a number of non-invasive or minimally invasive ways of taking care of veins. Injections, what we call ablation, which is where the saphenous vein, which is the big one that runs down the inside of the thigh, can be actually burned away using a laser or radio frequency energy. And so many of these are done because people have discomfort. Many of them may be done because of cosmetic reasons. And they're fairly straightforward and fairly safe to take care of.
Our viewers, I'm sure, are wondering, well, wait a minute, if I have some big varicose veins and they're very unsightly, are they susceptible to blood clots that'll break off and go up to my lungs and kill me?
They're susceptible to blood clots, but they can't go up to your lungs and kill you. And the reason for that is that the roots are too circumfluous. That is, a blood clot that develops in these small veins just can't find its way into the main deep veins.
Right.
There are some very rare examples where that's not the case, but 99% of the time, it's very painful. Superficial phlebitis is what we call it, and you'll notice that by a tender, red, hot lump somewhere on the leg. It can be treated with medication to make a lot of those symptoms go away much faster, but it does not pose that kind of a risk.
Okay. Let's then shift gears to the other important topic, which is arterial disease. Tell our viewers, first of all, how common is it to see arterial disease, for example, in the legs?
Well, it's very common, quite frankly. When we're talking about arterial disease, generally we're talking about what blocks arteries up. Now, you can throw blood clots from your heart. That's not really what we're talking about here. What we're talking about is diseases of the arteries. And almost always we're talking about atherosclerosis, hardening of the arteries. And that is a buildup of plaque in the wall of the artery. It's actually very common as we get older. In fact, if I believe neither you nor I smoke, which is one of the big precursors, and we've tried to lead healthy lives, but if we took one of our arteries and looked at it under the microscope, there would be some atherosclerosis. It's part of the aging process. Now, there are things that speed it up. Some genetics, they say that if you want to live a nice, long, healthy life, have parents that led a nice, long, healthy life. Yeah. That's very pertinent to the blood vessels in your body. Sure. Smoking, big one. And in fact, certainly in the Washington area, we've seen a big drop-off in atherosclerosis because in this area, a lot of people have really quit smoking, or it's almost impossible to smoke anyway. Yeah. Hypertension, that will cause the damage and cause atherosclerosis. And there's some other things, diabetes and some other issues.
How about high cholesterol?
High cholesterol, yes, and again, that goes back to genetics as well, because that tends to be a genetic issue, but absolutely. And actually even more pertinent to that is the fact that in addition to the fact that high cholesterol may lead to this, the new cholesterol medications, such as the statins, are tremendous at not only limiting that from happening, but actually have been shown to reverse the progression of it.
How interesting.
So the atherosclerosis builds up. Now, the real issue is, does it become a problem? Well, what you're talking about is blocking off arteries. And generally speaking, there are a lot of people over the age of 75 or 80 or 85 that have blocked arteries, major vessels that go into their legs. And yet they have enough blood flow that they don't even know that it's a problem. And that's because they can build up collateral flow. Collateral flow is the flow of small vessels that get larger and route the blood around the main vessels that are blocked.
A bypass.
They sort of an auto bypass. Yeah. The analogy that I make is if you and I wanted to get in a car right now and drive to Florida, we'd get on Route 95, and we could get a lot of cars on Route 95. We'd probably be able to go pretty fast, except, of course, through Northern Virginia. But if all of a sudden 95 was blocked off from, say, the North Carolina line to the South Carolina line, we'd get off at an exit that was with roads that were meant for local traffic. We'd weave our way around, and we'd get back onto 95. Mm-hmm. Those roads wouldn't carry as many cars. They couldn't go as fast, but we'd get there. That's what happens in people who slowly develop atherosclerosis of the legs. Now, let me step back for a second and say we're talking about the lower extremities, the legs. If we're talking about the carotids going to your brain, if we're talking about your heart, that's a different story and how that's treated. But for your legs, unless there's so poor blood flow that you are literally about to lose tissue, have gangrene, what we call rest pain, that means at night you're lying in bed and your toes are hurting because there's so little blood flow, most of this doesn't really need to be treated. Mm-hmm. And so the blockages in the arteries of the legs, although we do treat them in a fair number of cases, the only times you really are forced or have to treat them is when the cutoff of blood flow is so bad that people are looking to lose tissue. Mm-hmm. That is, you see ulcers or sores that are not healing, or in fact, as I said, rest pain. Now, the other big symptom, and actually much more common with respect to blockages in the arteries going down the legs, is what we call claudication. And claudication simply means that when you start walking at a certain distance, you have sort of exhausted the blood flow that is getting to the legs because it's restricted. It's being fed by the collaterals, but not by the main arteries. And chemicals build up in the muscle, what we call lactic acid, because you can't burn the sugar all the way to water and carbon dioxide. It sort of stops at an acid, and that hurts. Yeah. You stop, that washes out of the muscle, and you can walk again, and it'll keep happening at that distance. Now, when that happens, the main treatment for that, once you've determined that it's from a blood vessel problem, an artery problem, is number one, what we call behavior modification. Do you smoke? Don't smoke. Are you walking? Walk more. That may help. And in fact, use a statin. That may also help. There's also one medication called Playtol that may help some people walk a little further when they have that problem. But claudication in and of itself can be certainly limiting to people's lives and how they live their lives, but doesn't in and of itself require treatment. You can wait till things get really bad before you're forced to treat the blood vessel restriction or blood flow restriction in the legs from blocked arteries. Again, that's a difference between the heart and the carotids, where that is the arteries going to the brain, where bad things can happen before you have an opportunity to do something about it. With claudication, we generally advise our patients not to do what we call interventional techniques, but there are a lot of ways of dealing with that without actually doing surgery. And what we call, people have heard about balloon angioplasties and stent placements and things like that. So we can open arteries with balloons and stents and restore the normal blood flow in many cases to the legs so people don't have a problem walking. But as I will tell all of my patients, they must understand that once you start poking sharp objects into people's bodies, things can go wrong. Mm-hmm. And so you don't enter into these things unless, one, you feel the patient feels very, very much that they're limited in what they can do, and two, that they understand the possible risks.
Are there any conditions associated with arterial disease? Any other?
Well, I mean, when you say conditions, there are certainly, we also deal with the small vessel disease.
Okay.
People who have Raynauds disease, which is a vasospastic disorder where normally if you and I go out in the cold weather, our fingers are going to get a little cooler because we're going to conserve central blood flow. But there are people who have a hyper response to that. And there they can actually get such a bad response that they lose enough blood flow to their fingertips or their toes, they can actually lose tissue, that is, develop gangrene. Mm-hmm. That can be treated with medication generally, or you move to Arizona and don't spend a winter in Washington.
Is there any higher risk in these patients with claudication for heart disease, stroke?
Well, that's an interesting point. Yes, and certainly if you have this atherosclerotic disease in your legs, there is a reasonable suspicion that you could have it from a cardiac perspective from your carotids. Now, I would sort of put the shoe on the other foot. If you think you have a heart disease, get checked for heart disease. And I'm not a cardiologist, but for example, there's a calcium score you can get these days and some other tests that you can do for your heart. But certainly if you have symptomatic arteriosclerosis of your legs, significant blockages, doctor can't feel pulses in your feet, and you're diagnosed as having this problem, you may not want to treat the legs, as we've talked about, but yes, you have to be concerned, could you have it elsewhere, heart or your carotids, where it could be an issue and you would have that checked out. Certainly, hopefully the patients have their internist, he knows these issues, he would be able to steer their patients in the right direction and get them tested appropriately.
Terrific. Dr. Ruben, thank you for a very informative interview. If our viewers have any questions, how can they reach you?
Well, you can reach me through my office. The phone number is 301-681-3900. Like I said, I'm a local boy. I'm right over here in the White Oak area of Silver Spring.
Thanks for joining us.
Thank you.
My thanks to Dr. Ruben for an excellent interview on vascular disease. My thanks to my terrific team here at the studio, and my thanks to you, the viewer, for welcoming us into your home. Tell us how we're doing. You can reach me at my practice website, montgomerygastro.com. As for our next show, I will be welcoming Dr. Bradley Bennett and Dr. Vivek Patel, noted colorectal surgeons, and they will be discussing surgical approaches to colon cancer, diverticulitis, and of course hemorrhoids. It's going to be a very important show. See you then next time for another edition of Housecall. Good evening.